Hello, I'm Dr. Rohit Chandwani, and I am a specialist in pancreatic surgery. Today I'll be discussing a few basic facts about pancreatic surgery to help you understand your operation. Today we're going to address several basic questions about the pancreatic operation, including the reasons for undergoing pancreatic surgery, how we decide if a pancreatic operation is possible, what types of operations we perform on the pancreas, and how we perform them. Lastly, we'll discuss what one can expect after undergoing a pancreas operation. Briefly, a few notes about pancreatic surgery. Several thousand operations are performed annually in the United States, and most of these are for tumors of the pancreas, or less commonly for chronic pancreatitis. Pancreatic operations are complex, largely because of the anatomic challenges of pancreatic surgery. One, the pancreas is located deep in the abdomen just in front of the spine, and two, it's a delicate organ that is rich in digestive enzymes, and that when these enzymes leak, they can cause inflammation in the vicinity of the pancreas. In addition, there are several important blood vessels that run adjacent to the pancreas, and these must be carefully preserved in any pancreatic operation. Often, these blood vessels can become involved by tumors of the pancreas, and so care and consideration must be taken to avoid damaging these blood vessels. What are the reasons for undergoing a pancreatic operation? Most commonly, it is to remove a pancreatic cancer, and by that I mean a pancreatic ductal adenocarcinoma, the most frequent type of pancreatic tumor. The other reasons for a pancreatic operation include several of the other masses that arise in the pancreas. These include neuroendocrine tumors of the pancreas, intraductal papillary mucinous neoplasms, or IPMNs, that come in three different types: branch duct, main duct, or mixed type, where the mixed type is a combination of the branch and main duct types. There are also mucinous cystic neoplasms and solid pseudopapillary neoplasms of the pancreas that can occur, although these are more rare. Of note, these various diagnoses in the pancreas carry very different prognoses. What are the key aspects of the evaluation of a patient who requires a pancreatic operation? Well, first and foremost, it requires the evaluation by a surgeon. Secondly, a gastroenterologist or medical oncologist may be involved in order to both make the diagnosis as well as to consider other treatment options, respectively. Some of the testing that might be performed typically includes a CAT scan or an MRI, and a gastroenterologist may be called upon to perform an endoscopic ultrasound and/or an ERCP, which is another type of endoscopic procedure that evaluates the pancreatic duct. In addition, lab tests are frequently ordered, and a biopsy may be indicated to establish the diagnosis. The goals of all of this testing and evaluation by various physicians of differing specialties is to arrive at a diagnosis that determines the need for surgery and not necessarily the exact type of tumor. In the case of masses that require resection, there should be no evidence of spread to other organs. There should be careful assessment of the involvement of nearby blood vessels and adjacent structures, and this is typically done by the operating surgeon. In addition, it is important to ensure that the patient is healthy enough to safely undergo a pancreatic operation and that there is a strong support plan in place for care after the operation. Once a patient is deemed fit for an operation and requiring one based on their diagnosis, there are multiple types of pancreatic resection that can then be considered. The first is the Whipple procedure, also known as a pancreaticoduodenectomy, because the head of the pancreas is removed along with the duodenum. The second common type of pancreatic operation is a distal pancreatectomy, which removes the left half of the pancreas, and this can be performed with or without a splenectomy. Additional types of pancreatic resection operations include a total pancreatectomy, where the entire pancreas is removed, or a central pancreatectomy, where the middle part is removed. These operations are less common and won't be covered in detail in this talk. The choice between these operations is really dictated by the location of the disease in the pancreas. This is an important consideration that must be made by an experienced surgeon. The Whipple procedure. This is performed for tumors in the head, neck, or uncinate process of the pancreas. As I mentioned before, this is also known as a pancreaticoduodenectomy and includes removal of the first part of the small intestine, which is the duodenum, the lower bile duct and the gallbladder, and the parts of the pancreas I mentioned before. Sometimes the last portion of the stomach is removed as well. Though of note, there is no difference in outcomes or in quality of life with removal of this portion of the stomach. The Whipple procedure features a complex reconstruction following removal of the head of the pancreas and the duodenum. Specifically, 3 new connections are made in the operating room. The first is that of the bile duct to the small intestine. The bile duct is typically the common hepatic duct that is connected to the second part of the small intestine called the jejunum, and as such, this connection is called a hepaticojejunostomy. The second connection that's made is that of the stomach or the duodenum to the small intestine. This is called either a gastrojejunostomy or a duodenojejunostomy. The third connection involves reestablishing continuity of the pancreatic duct with the small intestine. That connection is called a pancreaticojejunostomy. Overall, the resection and reconstructive phases of the operation take 3 to 4 hours to complete, and the operation is most typically done via a traditional open incision that is made in the middle of the abdomen. There have been many centers that have published data on performing this operation in a minimally invasive fashion. However, there is yet to be evidence to show that there are superior outcomes when performed in this manner. What is the recovery from a Whipple operation? On average, patients spend 6 to 8 days in the hospital after surgery. They are walking the day after surgery. The urinary catheter is usually removed, and the patient is able to shower on the 2nd or 3rd day after the operation. Typically, the patient is eating solid food within 4 to 5 days of the operation, and when they are discharged home, there are no dietary restrictions, and the bowel function is usually returned back to normal. What are the complications of a Whipple procedure? The most common complication of a Whipple is leak, and that leak most commonly occurs from the new pancreatic duct to small intestine connection, or anastomosis. The rate of that complication is approximately 10 to 15%. The other complications include bleeding and infection, which typically occurs of the wound itself. There is a rate of mortality from this operation, which is less than 1% at experienced centers. Most of the complications, namely that of leak and of bleeding, can be managed endoscopically by a gastroenterologist or percutaneously through the skin by an interventional radiologist. It is very rare these days to require reoperation after a Whipple procedure. What is life like after a Whipple? Most patients can eat normally, but appetite is usually diminished for a few months. Many patients are worried about the impact of removing the gallbladder or the impact of removing a small part of the stomach. Most commonly, however, there is no impact of removal of either organ. Many patients also worry about the possibility of diabetes after removing a part of the pancreas, given that the pancreas is the source of insulin. New onset diabetes is very rare, however, but patients that are diabetic before surgery might require more medication to control their blood sugars. Energy and activity gradually return to normal over 6 to 12 weeks after the operation, and patients who worked prior to the operation can typically resume working. Let's now turn to a distal pancreatectomy. This is another common operation performed on the pancreas, and it's typically performed for tumors in the body or tail of the pancreas. Also known as a left pancreatectomy, this frequently includes removal of the spleen. No reconstruction is required after a distal pancreatectomy, meaning that there are no new connections made. The remainder of the pancreas is either sewn or stapled to prevent leakage from its end. This operation usually takes about 2 to 3 hours to complete and is most often performed via a minimally invasive technique, meaning either laparoscopy through several small ports placed in the abdominal wall or robotically. What is the recovery from a distal pancreatectomy? On average, patients spend 3 to 5 days in the hospital after the operation. As before, they are walking the day after surgery. The urinary catheter is removed the 2nd day after surgery, and patients are typically able to shower at that point. They are typically eating solid food within 3 to 4 days, and as before, when they are discharged home, there is no dietary restriction and the bowel function has returned to normal. What are the complications of a distal pancreatectomy? They are highly similar to that of a Whipple procedure. The most common complication is leak, and that leak most commonly occurs from the cut surface of the pancreas. That leak rate is approximately 20%, and that is the reason why we typically leave a small catheter to help drain the area should there be any fluid that accumulates from the edge of the pancreas. The risk of bleeding and infection and death. The other complications of the distal pancreatectomy, bleeding, infection, and death, are more rare than they are for a Whipple, and are extremely uncommon. Most complications, as with a Whipple operation, can be managed either endoscopically or percutaneously by either a gastroenterologist or by an interventional radiologist. As before, reoperation is extremely rare. So, to conclude, there are three important considerations to take note of. 1. A thorough, multidisciplinary assessment of each patient is necessary to determine the role of an operation in their treatment. 2. An individualized treatment plan is tailored to each patient to determine the timing and sequencing of therapy and to decide upon exactly how a surgical approach fits into that treatment plan. Third, while pancreatic surgery is complex, the main operations on the pancreas, the distal pancreatectomy and the Whipple procedure, can be performed safely in the hands of an experienced pancreatic surgeon. I have been told that because of my tumor, I am not a candidate for an operation. Should I get a second opinion? Yes. Centers can differ in their approach to the treatment before surgery and sometimes to the treatment of involved blood vessels near the tumor. While in most cases the approach will be the same, in some cases there may be some benefit to obtaining a second opinion. I have been told that I need a Whipple procedure, but I hear that it is a very risky operation. Is that true? Historically, the Whipple operation was in fact associated with a high rate of morbidity and mortality. As recently as 15 to 20 years ago, the operation would last 6 to 8 hours, and patients would spend a couple of days in the intensive care unit. However, recently, technical refinements have dramatically reduced the duration of surgery as well as the length of stay in the hospital. For more information, you can call one of our surgeons in the section of hepatobiliary surgery and liver transplantation at Weill Cornell Medicine at 212-746-2127, or visit us online at either our Department of Surgery website or at the website of our pancreas program. Thank you.